Good afternoon. Welcome to today's webinar about lessons from recent disease outbreaks and how they relate in a time of SARS-CoV-2, provided by the Pennsylvania Medical Home Program, which is a program of the Pennsylvania chapter of the American Academy of Pediatrics. The Pennsylvania Medical Home Program is honored to have been selected by the American Academy of Pediatrics for this presentation opportunity through the Visiting Immunization Expert Initiative for supporting pediatricians to increase human papillomavirus and pediatric influenza vaccination rates. Those efforts were led by Eileen Thompson, who is a program director and a superhero at the PAAP chapter. So thank you to Eileen for making this opportunity available to our medical home program as well as the chapter at large. This webinar is led by Dr. Richard Moriarty and aims to examine roots of vaccine hesitancy in recent vaccine-preventable disease outbreaks, to understand techniques used to stop vaccine-preventable disease outbreaks, and to discuss ways of applying these lessons in a time of SARS-CoV-2. My name is Dr. Renee Turchi, and I'm a pediatrician at St. Christopher's Hospital for Children in Philadelphia, the medical director of the Pennsylvania Medical Home Program at the Pennsylvania chapter of the American Academy of Pediatrics. This webinar is being recorded and will be available upon request. Please be advised that none of the speakers today have any disclosures. And please note that the information presented in the webinar is educational in nature and does not necessarily represent the views or policies of the Pennsylvania chapter of the American Academy of Pediatrics or its funders. It is now my special pleasure to introduce Dr. Moriarty for our presentation today. Dr. Moriarty graduated from Colby College and the University of Vermont College of Medicine. He completed his pediatric training at Johns Hopkins Hospital and University of Rochester. He practiced primary care pediatrics in the United States Navy for 10 years and then completed a fellowship in pediatric infectious disease at the Walter Reed Army Medical Center. He continued to practice both pediatrics and pediatric infectious diseases at the National Naval Medical Center and Walter Reed, serving in several positions, including chair of pediatrics and then as Joint Pediatric Residency Program Director for the programs. He retired from the Navy after 23 years of active duty and then moved to the University of Massachusetts Medical School and UMass Memorial Healthcare, where he served as Pediatric Infectious Disease Consultant, Pediatric Primary Care Physician, Head of the Pediatric Travel Medicine Clinic, and Consultant for International Adoptions and Physician Leader for the Pediatric Primary Care and Subspecialty Clinics, which served over 50,000 patients annually. For 18 years, Dr. Moriarty has been an active member of the Massachusetts chapter of the American Academy of Pediatrics Immunization Initiative and has provided over 24 immunization updates to care providers across the state of Massachusetts. Since retiring from clinical practice in 2015, he has provided more than 30 vaccine update conferences around the state. He is working with the Massachusetts chapter and the American Cancer Society to increase HPV vaccine uptake and has been working on an American Academy of Pediatrics chapter project to increase vaccine confidence. He has also been active in efforts to end the religious exemption for school vaccines in Massachusetts. He has won numerous teaching awards and in 2014 was recognized as the CDC Childhood Immunization Champion for Massachusetts. We are truly delighted and honored to have Dr. Moriarty present today. Thank you so much for being with us, Dr. Moriarty, and at this time, if you could please begin your presentation.
Thank you very much, Dr. Turchi, and it's a pleasure to be with you today, and thank you to the Pennsylvania chapter of the AAP for extending this invitation to me. We've already talked a little bit about the objectives. Dr. Turchi mentioned those, so we will start off. Really invented in 1796, and it only took about 4 years before there was an anti-vaccination society in London. So the evils of this smallpox vaccination, that cows would start to sprout out of your body if you got this vaccine. A century later, in 1902, an anti-vaccination society was formed in the United States. And as the slide said, they were looking for half-mad, misguided members to join this group. We see today online that the anti-vaccination movement has grown and certainly become more visible and more vocal. And of course, they have a big presence on social media. How did we get to this point where there is so much vaccine hesitancy or anti-vaccine feeling when vaccines have done so much good? And to understand this well, it's worth going back a little bit. The first big incident that I would discuss in the United States is a bad batch of polio vaccine made by Cutter Pharmaceuticals in 1955, right after the polio vaccine was approved. It was supposed to be a killed vaccine, but in fact it wasn't completely killed, and as a result of this, 40,000 kids were infected with polio. 200 were paralyzed and 10 kids died from this. In 1976, the swine flu vaccine that came along caused an increased incidence in Guillain-Barré syndrome. Then in 1982, there was a show on television about the evils of the DPT vaccine, the whole cell vaccine that was used then. This led to an organization called Dissatisfied Parents Together, DPT, which has subsequently morphed into the National Vaccine Information Center, which is a big source of anti-vaccine and vaccine hesitancy discussions. Going on a little bit, as more vaccines were added onto the schedule, the FDA decided in 1997 to review thimerosal that was in many of the vaccines, although thimerosal had never been shown to cause any problems from it being in the vaccine. The thimerosal, as you know, was taken out of the vaccines, virtually all vaccines now except for the multi-dose vials of flu vaccine. Then in 1998, a huge hallmark in the anti-vaccine movement when Andrew Wakefield published his article linking MMR vaccine to autism. Then we go a little further. In 1998, the very first rotavirus vaccine was approved and was very shortly after it was started to be used was withdrawn because of a slight increase in the incidence of intussusception. Senator Dan Burton from Indiana had multiple hearings in the U.S. Senate about MMR and autism. Then there were many other voices that chimed in. People were saying, we never see these diseases anymore. There are too many of these vaccines given too soon. And just a couple of years ago, there was a study that showed that Russian trolls and bots were involved in inflaming the vaccine discussions on both the pro side and the anti side. So with all of these events, we've developed in our society in many situations a distrust of government, a distrust in big pharma, and certainly the opioid outbreak that's been going on for a number of years didn't help that. We've been a victim of our own success in that we're seeing the disappearance of many of these vaccine-preventable diseases, so people don't know how bad things like measles and meningitis and pertussis to much extent can be. We've seen the spread of gout on social media spread like a virus that's out of control. And many people are claiming that as vaccines are added to the required schedule for school, they're losing control over what goes into their body, and they're losing liberty to make their own decisions about that. And then, of course, now with COVID going on, Operation Warp Speed and race and finalists and all of the discussions that have gone on about a vaccine, people are very concerned about, with this track record, can we trust the government to come up with a good, safe, effective vaccine? We know that vaccine programs, immunization programs, go through an evolution. As the disease is rampant and vaccination starts, the incidence of disease goes down as the incidence of vaccine coverage goes up, but then people report either perceived or real adverse events. These adverse events cause people to lose confidence in the vaccine, so the immunization rate goes down, the disease outbreaks go up again, and then as people resume confidence in vaccines, the vaccine campaigns are successful, and at least with smallpox, the disease was eradicated. We are partway along to eradication with polio. And we are a little bit less far along with efforts to eradicate measles. But with the vaccine hesitancy that's going on, as you know, this in the last year and a half, the World Health Organization says that vaccine hesitancy is really one of the top 10 threats to global health. And so we really do need to think about addressing this. We know from studies here and around the world that there are pockets of under-vaccination. These usually occur in close-knit communities, and we'll talk about some of these outbreaks as we go on. In many situations, the circumstances from one of these closed communities or lowered immunization communities are different from one area to the other. And so what might work in one area may not work in another area. The top graph on this chart is from data that our Department of Public Health put together in Massachusetts looking at county rates of immunizations. Massachusetts has one of the best childhood immunization records in the country, but there are several counties that are well above the rest of the state as far as exemptions for vaccine, and virtually all of these exemptions are religious exemptions. New York, which is illustrated in the lower map, has pockets of low areas of immunization across the state. We know that there is a continuum of vaccine hesitancy. Fortunately for us, many of our patients accept all of the vaccines. Some people will accept even though they have hesitations, and it goes all the way up to a very small, fortunately, percentage of people who refuse all vaccines. But there are a fair number of people around this, along this continuum who are hesitant about the vaccines that they're getting. One of the things that's critically important, I think, is to talk about measures that can help remove vaccine hesitancy by boosting our own confidence in the vaccines that we use. There have been multiple studies that show that parents trust healthcare clinicians more than they trust movie stars, more than they trust other people. And one of the things that will help us get through to more patients, studies have shown, is to work on developing a trusting relationship with our patients. And there are several methods that we can do to accomplish that. First of all, it's important that we create culture of immunization in our offices and in our practice. And we should be putting this information on our websites, in newsletters, in posters around our offices, and shouting from the rooftops that we believe in immunizations. One of the key things here, and I highlighted this in red, is that it's critically important that all staff in your offices have to be on the same page with these messages. The story that I can relate about that is several years ago, one of the speakers from Centers for Disease Control came to speak about immunizations in Massachusetts, and she told the story about taking her 11-year-old daughter in for her middle school physical exam. The nurse took her into the office. The nurse did not know that this was a physician from CDC. And the nurse said, your child's going to have some shots today. There's TDAP and there's meningococcal vaccine. And then there's this other vaccine called HPV vaccine that can prevent sexually transmitted diseases and cancers later on. And the physician from CDC said to the nurse, well, would you get that shot for your daughter? And the nurse said, my daughter's not that kind of girl. And so the message was totally wrong. And we really want to make sure that everybody in the office, in the practice, is speaking the same thing. We've done some HPV uptake improvement projects around the state of Massachusetts, and one of the things that we found is that in some practices, the doctors are not all on board on exactly when to give the HPV vaccine. So it's something that practices need to work out, and everybody in the office needs to be on the same page. We know that there are evidence-based strategies that can help improve communications about vaccines. For accepting parents, it's pretty easy. You give a presumptive recommendation, we'll talk about that, and a blanket recommendation. For vaccine hesitant parents, it's a little more of a challenge. But motivational interview and a proper way to debunk myths can really be very effective. If a patient comes into an office and the first thing the doctors or the nurses say is, which vaccines would you like today, it doesn't portray a feeling of confidence about those vaccines. And sometimes parents will wonder, well, doesn't my healthcare provider know what vaccines I should have? So we need to be starting out with the right message. Today your child is due for these vaccines. These are the recommended vaccines to prevent these diseases. Those are positive, presumptive statements that can give a good message, and that alone can help improve vaccine uptake. Blanket recommendations, again, people talk about same way, same day. For your child is due for TDAP to prevent those diseases, HPV to prevent certain kinds of cancer, and the meningitis vaccine to prevent a very serious brain infection. You want to make sure that you're giving equal weight to all of the vaccines. I remember in 2005 when the HPV vaccine came along, we had not been really taught well how to discuss this vaccine with people. And I can remember saying to people whose kids were 11 years old, your child is due for TDAP today and meningococcal vaccine today. And then there's this new vaccine for HPV which can prevent cancer later on. And they honed right in on new vaccine. The first thing that people said is, oh, it's not very well tested. So you want to make sure when you're presenting these vaccines that you present them all in an equal way. Motivational interviewing is another technique that has been shown to be very effective. And with this technique, you can build trust, you can understand where patients are coming from and what their belief systems might be. You can work with families to help reach the goal of fully immunizing the kids. The best way to think about this is to look at, there's a link to a video on the bottom of this slide, which was just done by Amanda Dempsey from Denver, who is a real expert on motivational interviewing. And she presented this for the Mass chapter of the AAP. I'd urge you to watch that webinar to get the specifics about motivational interviewing. But just to mention them briefly, empathizing with people, collaborating with them to try to find out what their issues are and addressing them, asking open-ended questions, and going from there. It's also important to realize that even when you talk with families, they may still, and give them the right information and do things right, they may still decide not to do a particular vaccine. If at first you don't succeed, try the next time, and a couple of studies have shown that there's about 30% of the people who refused once will come back and do it the next time. So that's important. Going through some of these, this motivational interviewing, Dr. Dempsey has said that it takes only about 10 minutes, which seems like a lot of time, but that 10 minutes can save us time down the road as we've built the trusting relationship and and help give people the correct information about vaccines. Vaccine confidence in your office is important again. Telling your own stories. I immunize my own children. I've seen this particular vaccine preventable disease. We've found that at meetings it's oftentimes been helpful to recruit a parent of a patient who's had a vaccine preventable disease, or a parent who has lost a spouse from HPV-related cancer, in helping get the message out, because oftentimes these are things that make a big impression on people. So all of these things can help improve the confidence in vaccines in your own offices. One of the things, the reference that's worth looking at is what's called the Debunking Handbook. There's a link below. You can download this booklet for free. And it talks about how to talk with parents who have particular myths or concerns about the vaccine. And if you talk with somebody who believes, for instance, that the flu vaccine causes the flu, and then you give them 400 reasons why it actually can't happen, they're left with so much information that the only thing left is the myth. On the other hand, if you say, no, that's not true, the vaccine, for instance, is made by components of virus that are not infectious and can't cause the flu, you've given them one idea that they can think and process. One of the things that we have found helpful in Massachusetts is providing some information to families who choose not to vaccinate. And what will this actually mean for your child? And one of the big things is the possibility of exclusions from school or daycare if there's a vaccine preventable disease in the school or daycare. And one of the things that Massachusetts has made available is this is the digestion of the 2-page handout that Massachusetts DPH makes available to say for parents to say, these are the exclusion guidelines. If there's a case of mumps in your school, your child is out of school for 18 days from the onset of symptoms of the last case. The same with pertussis, and mumps and pertussis are two that we have seen some outbreaks of in the state. So giving this information to parents might help them decide, do I really want to risk this possibility? Vaccine confidence in your communities is also important to work on and think about. We've started a vaccine confidence building project in some of the areas in our state where there is low vaccine uptake. And we've also found that helping publicize information in schools, in hospitals, even in libraries about the importance of immunization can be helpful in building community confidence in vaccines. One of the things that was very helpful for us in our HPV program was to put a coalition together of groups who were very interested in making sure kids were immunized. We had not only hospitals and pediatric practices, the AAP, the American Cancer Society, but we had survivors of HPV-related diseases. We had dental professionals who were going to talk about the importance of oral exams for HPV-related cancers and the importance of vaccine to prevent head and neck cancers. So all of those things can be very helpful. Let's talk about a couple of specific outbreaks and then some lessons that we've learned from them. In May 2017, there was a big outbreak of measles in Minnesota. Minnesota has one of the largest Somali communities in the United States. Autism is something that was not recognized really in Somalia, but around 2008, there was a program that was started in Minnesota to screen school-age kids for autism, and a fairly high number of Somali children were identified with autism. Around the same time, Andrew Wakefield, of all people, came to the Somali community and teamed up with other vaccine-hesitant people and talked to the community. So the rate of MMR vaccine in the community dropped significantly. And there was an outbreak of measles in 2017, 79 cases, almost 30% were hospitalized. Most of them were unimmunized, and it cost the state $2 million to deal with this. One of the key factors in helping stop this outbreak was Department of Public Health partnering with community health leaders, community caregivers, and local clergy in particular. They provided multilingual communications for those who could read, translators in situations where people couldn't read, and those things significantly helped. In New York State, there was a big outbreak of measles that you've probably read about. And the references at the bottom from the New England Journal of Medicine give you much more information about that outbreak. An unimmunized U.S. citizen came back from Israel incubating measles, and he managed to do a good job of spreading it around his community. The vaccination rate in his community was only about 79% when that happened. This outbreak, where 649 people were infected, cost the state of New York $8.4 million to deal with. A group in that particular neighborhood had put together a pamphlet called Parents Educating and Advocating for Children's Health, called PEACE. Well, the problem was this PEACE manual was filled with anti-vaccine information and falsehoods about vaccines. Measles, as you know, is probably the most of the contagious diseases that we deal with. And one infected person walking into a room with unimmunized people can infect 12 to 18 other people. So because that reproduction number is so high, herd immunity levels need to be very high for measles. And we've seen in these two outbreaks that the herd immunity rate, the immunization rate, was about 75% in those communities. We're a plane ride away from some of these places where measles is endemic. One of the things that helped this outbreak end was a group of pediatric nurse practitioners got together and said, we've got to do something. So they put together a booklet called Parents Informed and Educated, and their slogan for this was Make Pie Out of Peach. And they went into individual homes with small groups of other neighbors, and they talked about the disease. They talked about the vaccines. They talked about the fact that you've been getting information that's not correct. Here is the right information. Along with that, of course, the Department of Public Health in New York had active case detection. There were immunization clinics. The area was under a public emergency declaration for a period of time, and the outbreak finally stopped. In Samoa, you've seen about the outbreak of measles that was there. 2 toddlers died after getting MMR, which turned out to be a vaccine mistake when expired anesthesia was mixed with MMR vaccines. But unfortunately, through Facebook, distrust about vaccines and MMR spread rapidly on the island. The MMR vaccination rate fell dramatically, and then lo and behold, a traveler from somewhere else came with measles, and in a very short period of time, 5,700 people were infected. There were 83 deaths, and this all in an island population of 210,000. So Facebook is a major information source unfortunately, for too many people. The Samoa outbreak was finally under control with very stringent measures. They locked down the island. They closed schools. They even canceled Christmas celebrations. They had house-to-house vaccination campaigns, and finally ended up arresting one of the main anti-vaxxers for spreading malicious information. In Washington state, there have been a couple of measles outbreaks, and again, low immunization rate overall in the state led to this. Most of the communities where the immunization rate was very low were Russian Orthodox-based communities, many who had emigrated from Eastern Europe, where there was a lot of distrust of government and a lot of distrust in vaccines in general. As a result of that, those outbreaks, Washington state ended their personal exemptions. Unfortunately, that doesn't usually go as being much help. The Archdiocese of Seattle actually ended religious exemptions for people attending parochial schools. So those are some of the things that we've seen as a result of outbreaks. We know that there are outbreaks around the world. If you look at World Health Organization data on this map, the darker the color is, the higher the incidence of measles in those areas. And yeah, I wish I could overlay a airplane travel route over this map, because there is just tremendous back and forth between countries. And it's easy to understand how vaccine-preventable diseases, particularly ones that are respiratory spread, can spread so far and wide. So we've learned a number of lessons from these vaccine-preventable disease outbreaks. We're only a plane ride away from where these vaccine diseases are happening. We know that pockets of underimmunization exist, and those pockets are fertile grounds for outbreaks. The reasons in the different pockets may be different, so it's important to get into the communities to find out what the reasons are and to help address those in an appropriate way, because it's not going to be one size fits all for changing minds. But we also need to think about re-examining immunization laws in every state too. We know that social media is a very powerful tool, and unfortunately too many people get their messages from their news from social media. We need to, as a community, participate more in social media to make sure that we are presenting the correct information. And we'll talk about that in a second as we go on. And there are some tools that are becoming available now to help us with this. There are some very good websites here. Two that I will talk about in particular on this slide. Shots Heard Round the World is a group that was put together by Todd Wolin's pediatric practice in Pittsburgh. And this is a Facebook group who has been used to call in the cavalry to help post good immunization messages when anti-vaccine people start to overwhelm a practice's website because they've posted information about vaccines that's positive. His group also put together this anti-vax toolkit to help practices sort of make sure that their websites and media information are safe from anti-vaccine attacks. So these two resources are very helpful to use. We'll talk about the other ones in just a couple of minutes. Another tool that you can use to educate people is this tool called FRED. And I can never remember what the acronym stands for. Oh yes, it's Framework for Reconstructing Epidemiologic Dynamics. Well, it's much easier to say FRED. But this was developed by the University of Pittsburgh. And this is a program where you can pull up virtually any state in the country except Wyoming. You can look in that state and pull up a number of different cities and see what an outbreak of measles would look like with a 90% immunization rate in the city versus an 95% versus 80% coverage. And again, those outbreaks that we've talked about had lower than 80% coverage. This is just a screenshot on the left of what a measles outbreak would look like in Philadelphia County with an 80% immunization rate in the county by the time 90 days had gone on. This is what the measles outbreak would look like in 90 days if there was a 95% rate. Virtually no cases and a couple of people who had recovered. So this can be a very good visual tool to show people. A brand new tool that is coming along is called Project Vector. And this project has been put together by several public health folks who are very interested in making sure good messages about vaccines get out. There's a YouTube video here that you can watch. There's a link to that. And then you sign up to be a member of a member of the Project Vector. You don't have to do anything, but then you will find the information that they are tracking, which involves looking at anti-vaccine postings on Facebook, Twitter, Instagram, Reddit, and a couple of other social media platforms. And it looks at the discussions. It looks at who is talking about these, who might be authoring those, and you can find out specific information about anti-vaccine discussions from your area. They also demonstrate hashtag clouds and word clouds, and I'll show you what those look like here. And we know from this that vaccine opposition conversations have drastically increased since COVID-19 has come along. This is what the country view looks like, and the states that are in colors are ones that Project Vector has data for. And they are looking to add the rest of the states to this by the end of this year. Massachusetts was in the group with Pennsylvania that most recently got added to Project Vector. And just as a couple of very brief screenshot examples here, this is a screenshot from about a 4-week period between August and September. 72,000 messages on social media about vaccinations. And the most common topic was COVID-19, but there were other topics that were there too. It also, just a screenshot from October 3rd, a couple of days ago, showed that in Pennsylvania, negative attitudes about vaccines were the prominent discussion. And if you looked at other topics that came up in these discussions, this is the word cloud. So vaccines, and there are a few good ones here, but then there are other ones: autism, learn the risks, informed consent, wake up America, that are anti-vaccine. So this is a good way of tracking by social media what's going on in your area. So it may help your discussion with patients, and it may help you any education efforts that you can do in your communities. Go back to the Constitution for a minute. The United States Constitution, one of the items in the preamble of the Constitution as a function of government is to promote the general welfare. A short history lesson here. Massachusetts had a law that children had to receive smallpox vaccination. And in 1901 to 1903, there was a smallpox outbreak in Boston. A bunch of people died from this. They re-brought up that law, and there was a Reverend Henning Jacobson up at the top here who refused vaccination for his son. He took the case to court. It went through the Massachusetts court system and went all the way up to the Supreme Court. And the Supreme Court, in a 7-2 decision led by Justice John Marshall, said that vaccines can be ordered to protect the public, a legitimate exercise of the state's police power to protect the public health and safety of its citizens. Local boards of health determined when mandatory vaccines were needed, thus making the requirement neither unreasonable or arbitrarily improved. And you can look up on, there are a number of sites online that will go into this decision in more detail. And by the way, this decision has been upheld a couple of times before for what precedent might be worth now in this day and age. We know about the importance of public health. One of the discussions that has gone along recently is that this COVID pandemic is more than just a pandemic. It's a pandemic being overlaid by so many disparities. Disparities in income, disparities in housing, disparities in healthcare, and some people have called this a syndemic. And again, when a group of public health folks from upstate New York were asked about what they thought of when they heard public health, this word cloud is what showed up. And these are the things that we really need to be working with as time goes on. We need a good public health system so we can be prepared for the next pandemic, which will come. We need good materials, PPEs, medicines, equipment that are sourced locally. We need rapid response with testing and timely results. All of these things, I think there has been so much discussion about recently. And we need to use things like Project Vector to find out what's publicly circulating as far as rumors and try to get ahead of them so we can make sure people have good information. Public health is really a key to helping prevent future epidemics or to minimize the possibility of future pandemics. And there have been a number of strategies that you've probably read about, whether it's pooled testing and wastewater from college dormitories or the possibility of home testing for agents like COVID. Testing programs need to be run. Their data needs to be collated, not just on a local basis, but on a national basis too. And we need to be measuring more things like test turnaround time and mask wearing to show its effectiveness. There are wonderful resources that are available. And again, if you haven't looked at some of these websites, I would really strongly urge you to. Immunize.org and Voices for Vaccines, you can sign up on those websites for a weekly newsletter, which are both very good. Voices for Vaccines is a parent-based organization. The CDC and the Vaccine Education Center at CHOP are superb. The American Academy of Pediatrics has great resources. A couple of blogs that I like are ZZ Dog's blog. Dr. Zubin Damania is an ER doc, and Skeptical Raptor is a very good website that helps shoot down some of the anti-vaccine tropes that are going around. So good resources are available. I'd urge you to explore them if you haven't already. To try to sum this up, vaccine hesitancy has deep roots and many different causes. Trust is an important thing, and we want to be working on trusting relationships with our family and making sure we have good information for them. Confidence in vaccines is important for us to demonstrate, and each vaccine preventable disease outbreak can teach us different lessons. We need to have a good presence on social media, and a good public health infrastructure is key in making sure that we stay healthy in the future. I would be happy to try to answer any questions if people have them. It's been a pleasure to talk with all of you.
Thank you so much, Dr. Moriarty. That was an amazing presentation. We actually do have some questions. So one of the first questions are, can you share some specific examples of social media examples used in Massachusetts to increase compliance for immunizations?
Yes. When our HPV campaign first started, one of the things that DPH did was they started a Facebook page about HPV vaccine and its importance, a Twitter account that was posting good information about vaccines. So the social media can be used to get out good information.
That's great. Another question we have is, we know that many immunization decisions are made while a woman is pregnant. Any thoughts about how to do a better job reaching pregnant women and partners?
Yes, and it's critically important. I'm sorry I didn't mention that. But as one of the audiences that we've been talking with here about HPV vaccine, we've been talking with OB providers about HPV vaccine and have taken that opportunity to, oh, by the way, while we're here, please talk about the importance of vaccines for pregnant women, for TDAP and hepatitis B testing, and making sure that they are immune to the vaccine-preventable diseases. And to plant the seed with OB to talk about the importance of vaccines for your baby after your baby's born. So that is very important to do.
Another question we have is, have you worked with the National Medical Association, Doctors of African Descent, suggestions for collaboration?
No, we haven't, as far as I know, but we did have several immigrant groups involved with our HPV campaign in the state. And we went to the, we partnered with the healthcare organizations that provided care in some of the lower income areas in Massachusetts to help get the message out. So partnerships are important, and finding out who are stakeholders, who are important organizations to be involved can be an important part of this too.
That's great. And a couple participants were stating that they really appreciated the length of resources that you had, so we appreciate that as well. If there's any further questions, you can type them in the Q&A box.
And if anybody does have any questions that don't get answered today, they could pass those on, and I'll do my best to answer them later on. Do you may I ask a question? Are there any things in particular that you have seen in Pennsylvania as far as specific worries that people have about vaccines, or specific obstacles to getting people immunized?
Oh goodness, that could be another hour discussion, correct?
Yes, it could be, but maybe I'll answer that with another sort of a reminder too. Virtually every state now has seen, with COVID and the shutdowns that we've had, so many kids are now behind in vaccines. There were several months this year when in Massachusetts the DPH said that there were 60 to 70% fewer orders for vaccines than there had been during the equivalent period last year. So we know that kids are behind in vaccines. And it's important to think about that, particularly in the medical home practices, and to make sure that we're doing what we can to make sure kids get updated. We also know that flu season's coming up, of course, and although when you looked at the Southern Hemisphere last year, they had relatively mild flu seasons, and now with people wearing masks, hopefully, or some people wearing masks, hopefully we will have a mild flu season here, but you never know. And what we don't know much about at this point is what can happen if somebody were to get influenza and COVID-19 at the same time. We know co-infections with viral respiratory infections are possible and very common. We know that sometimes co-infections make a disease worse than usual, and certainly that's a possibility with COVID. So it's very important to think about encouraging flu vaccine this winter in particular. I certainly appreciate the opportunity to share some thoughts and comments with you today.
We would like to express our deep appreciation to you, Dr. Moriarty, for your timely and informative presentation. We also want to thank Eileen Thompson for submitting the application to National American Academy of Pediatrics for this presentation opportunity that she made possible for all of us through the Visiting Immunization Expert Initiative. Thank you, everyone, for your participation today. Stay well. Everyone get their flu shots. And this concludes